Bismillah ar-Rahman ar-Rahim. Dear colleagues, it's my pleasure to be with you today on the 15th annual meeting of the Lebanese Society of Allergy and Immunology. This is the title of my talk, Food Allergy, the Risk Factors and Prevention. I have no conflicts of interest. My talk today will walk you through the risk factors that can predispose to food allergy, and in so doing we will try to pinpoint the modifiable risk factors that can prevent food allergy or may also induce tolerance. I brought you this slide from Egypt summarizing the frequency of allergy to the different foods among allergic Egyptian children. And as we can see here, that sensitization all through, these are the blue bars, sensitization as determined by skin prick test or by specific IgE was higher than actual allergy as determined and proven by oral challenge test. And we can see here that wheat is around 1.8%, peanuts as high as 2.5%, and bananas almost 2%. Very low frequency of allergy to rice and to strawberries. Seafoods also. Parental reporting of cow milk allergy among 1,300 Egyptian infants and children was 5.4%, whereas actual cow milk allergy, as proven by the oral challenge test, was only 1.8%. In a pilot study by Irani et al. On the prevalence of self-reported food allergy based on telephone survey, this was in Lebanon, of course, the prevalence was 4.1% in infants and children and 3.2% in adults. The major food allergen was fruits, followed by eggs, and then comes nuts and cow milk. Food allergy has been noted to occur as early as in the neonatal period, and in Japan, a multi-center survey reported a prevalence of 0.2% of milk allergy among neonates. And in an ICU in Japan also, 24 out of 2,000 had confirmed milk allergy. Is this because of prematurity and low birth weight? Well, studies have shown that they are not. Both prematurity and low birth weight are not associated with a change in the risk for food allergy in childhood. They might even be preventive. This figure shows the median postnatal age at onset of cow milk allergy, and in prematures it was on the 23rd day, whereas full-term neonates was as early as the 3.5 days after birth. This can be explained on the basis of immunological immaturity, and perhaps the development of food allergy needs a certain degree of immunological maturation. The exposure to food allergens starts in utero, and the amniotic fluid of 20 pregnant females was found to contain all these allergens. Perhaps even intact food proteins were found in the amniotic fluid, and this explains the reactions that occur to foods that have never been eaten before. Food allergens are also present in breast milk, and the RH2, the egg white, the cow's milk were all found in breast milk. Cow milk allergy also was recorded in exclusively breastfed infants at a rate of 0.5%. And the explanation here is that the dietary proteins that resist digestion pass on to the breast milk. What about mothers who are at risk of giving birth to an atopic child? Would you tell the mother to avoid the allergenic foods or to be exposed to these allergenic foods? This forest plot here shows that maternal avoidance during pregnancy or lactation was unlikely to reduce the risk of having an atopic child. As we can see here, that it was insignificant. Maternal elimination diets might even be counterproductive, that is, they produce the opposite effect. And a prospective birth cohort of 145 dyads, which means mother-infant pairs, they found that mothers who avoided cow's milk during breastfeeding had lower IgA against beta-lactoglobulin, and this led to the development of cow milk allergy in their children. So exposure of the mother to food allergens during pregnancy and lactation may be necessary for the induction of tolerance. The relation between diet and atopic diseases, including food allergy, has been extensively studied, and there are three main hypotheses related to vitamin D, to antioxidant, and to dietary fat. With respect to vitamin D, it can be articulated both ways, whether deficiency or excess. We will start by vitamin D, and we will see the prenatal and the postnatal effects of the vitamin D status. Prenatally, vitamin D insufficiency in Australian-born parents increased their likelihood of having infants with egg and peanut allergy. And in this birth cohort from CORK, which is a county in Ireland, they studied the relation between vitamin D exposure antenatally and the development of food allergy and other allergic diseases at 2 and 5 years of age. They found that maternal 25-hydroxyvitamin D was not different between atopic and non-atopic. The German LINA cohort study found that high vitamin D levels in pregnancy and at birth contribute to a higher risk of food allergy, arguing against vitamin D supplementation as a means of protection against allergic disease. They found an inverse relation between cord blood 25-hydroxyvitamin D and the Treg cells. The higher the 25-hydroxyvitamin D, the lower are the Treg cells, which are protective against allergy. The same controversy applies to vitamin D postnatally, where some say it's the deficiency and others say that the excess is related to the development of food allergy. Researchers from the Australian Health Nuts study found that the odds of developing food allergy in children born in summer were 55% lower than those born in other seasons. Also, other observations said that those born near the equator had less food allergy than those born nearer to the poles, Earth poles. This map of the USA represents the regional differences in EpiPen prescriptions per 1,000 persons. The dark color represents more EpiPen prescriptions, denoting more anaphylaxis, perhaps due to food allergy. And this is seen in the northern parts of USA where there is less sunshine. On the contrary, the southern parts of USA, where there is plenty of sunshine, there was much less prescriptions for EpiPen. Here is another study that incriminates vitamin D deficiency to the risk of sensitization to milk and wheat. The potential mechanisms for development of food allergy in vitamin D deficient children was explained by Vasallo et al., and he stated that it could be due to compromised barrier function, altered gut microbiome, or affection of the antigen-presenting cells and the T cells. In New Zealand, they found that vitamin D deficiency was not associated with allergic diseases, whereas high vitamin D concentrations were associated with parental report of food allergy. Interpretation of the studies on vitamin D and its relation to the risk of food allergy is limited by a lack of the definition of a standard definition for vitamin D deficiency. And perhaps we need a study like this one by Professor El Gamal and my colleagues in Ain Shams University, in which they defined the critical level for vitamin D deficiency, which is a 7.5 nanogram per milliliter, below which asthma control is poor. So we need similar studies. A recent systematic review and meta-analysis in 2017 showed that there is no significant association between 25-hydroxyvitamin D and the risk of food allergy, and this was reached after analyzing 368 citations involving more than 5,000 children. Based on a cohort data analysis of more than 8,000 children in USA, the early vitamin use, including vitamin D, at the age in the first 6 months and at the age of 3 years, was associated with a higher risk for food allergies. As we can see here, the odds ratio is high, and it was significant. So perhaps the final word here is that of the World Allergy Organization, McMaster University Guidelines, or the GLAD-P, and the panel suggests not using vitamin D in pregnant women, in breastfeeding mothers, or healthy term infants for the prevention of allergic disease. This study from Poland on 202 52 mother-child cohort. They measured vitamins A and E and beta-carotene in the mother during pregnancy, and they kept looking for food allergy in the children up to the age of 2 years. They didn't find a significant association. Researchers from Vienna studied the effect of vitamin C and E, as well as food preservatives and colorants in vitro, and their effect on the asthma pathways and the allergy pathways. They found that these antioxidants inhibit the nuclear factor kappa B, and this results in inhibition of the T helper 1 autocrine activation, and this leads to predominance of the T helper 2 pathway. They concluded that there are no firm data to support the use of antioxidants to prevent allergy or asthma. So antioxidants act as a two-edged sword. They have an anti-inflammatory effect through their suppression of the T helper 1 pathway, where in the meantime they increase the prevalence of allergy and asthma through activation of the T helper 2 pathway. Folic acid supplementation is a usual practice during pregnancy. And when children with food or inhalant allergens were studied retrospectively, they found that they had higher frequency of mothers receiving above recommended doses of folic acid compared to healthy children, whether this supplementation was before pregnancy or during pregnancy, and the proposed mechanism was DNA methylation, suggesting an epigenetic mechanism. This is a nested case control study from the Boston birth cohort, and they found that higher unmetabolized folic acid at birth was associated with the development of food allergy, and perhaps we can say that avoidance of excess folic acid during pregnancy may give a better outcome or may be preventive of food allergy. Nutrition in early life is the most influential environmental factor during fetal development, and it was found that they act through epigenetic mechanisms, which affects the fetal gene expression and the disease risk. Nutrients can determine the atopic outcome of an infant or child through their effect on the gut microbiota, through programming the immune system, metabolic pathways, and also through epigenetic mechanisms by inducing DNA methylation. This starburst plot shows that the methylation scores of food allergic infants was higher than that of sensitized but non-allergic infants, and both had higher scores than normal non-atopic infants. Also, another cohort from West Australia shows that the scores for allergic was higher than for the non-allergic infants. The Mediterranean diet is ample with green leafy vegetables, fruits, olive oils, and adherence to such a diet during pregnancy was found to have a protective effect on asthma and wheeze in the offspring in the first year of life. The Western diet, on the other hand, has many oils and margarine and the fast foods and so forth, negatively affect the gut microbiome. Data concerning food allergy are poor and are deficient in the literature. And these are not my words. These are the words of the European Academy position statement in 2020. This takes us to the dietary fat hypothesis. And as we see here that the N6 polyunsaturated fatty acids increase the production of prostaglandin E and D2. And this leads to predisposition to atopy and increases the severity of the allergic disease. So exposure to N3 polyunsaturated fatty acids, which oppose the effect of the N6, can help prevent allergy. In a Cochrane systematic review, maternal supplementation during pregnancy or lactation with the omega-3 fatty acids has been found to decrease the relative risk of development of food allergy at the age of 1 year, and this was significant. This forest plot is from a meta-analysis of the studies on supplementation with omega-3 to pregnant women, and it was found that it decreases the incidence of positive skin prick test to hen's egg when compared to placebo. The overall effect, as we can see here, is highly significant. Supplementation also with omega-3 reduces the incidence of positive skin prick test to any food in the first 12 months of life. This holds true also for the development of atopic eczema in the first 12 months of life, and this was significant, and we know the link between atopic dermatitis and food allergy. So as we have seen that supplementation of the mothers during pregnancy with N3 polyunsaturated fatty acids was preventive for food allergy in the offspring, but in infancy such supplementation is contradictory. In a large birth cohort, regular fish consumption, which are rich in polyunsaturated fatty acids, was decreased the risk of allergic sensitization to foods by 4 years of age. However, a Cochrane review found no evidence for supplementation with polyunsaturated fatty acids. Another risk factor for the development of atopy is the maternal intake of sugar during pregnancy. The higher the quintiles of sugar consumed by the mother during pregnancy, the higher is the risk for atopy. And this is in the Avon study from UK, and the reference here is Johnny Johnny No Papa. There is a strong link between the presence of atopic dermatitis and the development of food allergy, and it has been found that between 20 to 80% of children who has or have had infantile eczema have IgE-mediated food allergy. This is especially true if the eczema is severe and more prominent if the eczema occurs in the first 6 months of life, where the risk for the development of allergy to egg, milk, or peanut is almost doubled. Why is food allergy more common in patients with infantile eczema? This is explained by Gideon Luck in the dual allergen exposure hypothesis, where the exposure through the oral route leads to the development of tolerance through the Treg memory cells, whereas exposure and entrance of the food allergens through the skin leads to sensitization and allergy through a T helper 2 memory. So the immune response resulting from cutaneous exposure to an antigen may lead to sensitization, especially in the presence of atopic dermatitis, and maintaining a healthy skin barrier will thus help prevent sensitization to food allergens. Another important point about infants with atopic dermatitis that is triggered by food. It has been found that when these infants were put on a strict elimination diet, 19% of them developed immediate reactions which they have never experienced before. These immediate reactions were either cutaneous in 70% of cases and more seriously anaphylaxis in 30% of the cases, and this developed after an average length of time of 1 year being put on an elimination diet. Hence, complete avoidance may not be the best management in high-risk children, even with food-triggered atopic dermatitis. Exclusion diets can inadvertently lead to loss of tolerance of foods and increase the risk of immediate reactions. Does the timing of introduction of solid foods count? Is it preventive for food allergy? Chan, in his review, states that delaying introduction of peanuts and other allergenic foods in children may have in fact contributed to the dramatic increase in the prevalence of food allergy in the recent decades. The LEAP study, or the Learning Early About Peanut Allergy, is the first prospective randomized controlled trial that compared the risk for the development of peanut allergy in children who are at high risk for allergy, as those with severe eczema, with egg allergy, or both. Those who consumed peanuts early in life and regularly had much lower prevalence of peanut allergy as compared to the avoidance group who avoided the intake of peanuts until 5 years of age. Consequent upon the LEAP study, the addendum guidelines were released by the National Institute of Allergy and Infectious Disease, along with other professional organizations, that recommends introducing peanuts at 4 to 6 months of age in infants at a high risk of developing peanut allergy. This was in 2017. Let's see if this applies to other foods as well. This recent review, published 2 months ago in September 2020, summarizes the results of important randomized controlled trials on the early introduction of food allergens, especially on egg, peanuts, and milk. The STAR study from Australia showed that early introduction of egg was associated with lower risk of egg allergy, but the results was insignificant. The same also with the EAT study, where the intention to treat analysis showed insignificant reduction. Of course, the LEAP study showed significant results with respect to peanuts. The HEAP study, on the contrary, done in Germany in 2017, showed that the opposite occurs. There is increased risk with early introduction. And here are two studies from Australia, the STEP and the BEAT studies. Both of them showed reduced risk of development of egg allergy with early consumption of eggs, but it was significant only in the BEAT study. In the PETIT study from Japan, 8% of the egg group had an egg allergy compared to 38% of the placebo group. And this was significant, with highly significant. And two systematic reviews with meta-analysis of randomized controlled trials, as we see here, advocate the early introduction of eggs as a means of preventing or reducing the risk of egg allergy. There was a notion here that better efficacy is obtained when using cooked eggs as opposed to raw eggs. Based on these studies as well as other studies, the major scientific societies coined the recommendations. For example, the QuadAI recommends introducing complementary foods between the age of 4 and 6 months. The ASPAGAN recommends not to introduce solid foods before the age of 4 months, but not beyond the age of 6 months. The British Society recommends the age of 4 months for those who have eczema or existing food allergy. What about cow's milk? The child study is a Canadian study on a cohort of 2,100 children, showed that delayed introduction of cow's milk as well as egg and peanut beyond the first year of life significantly increased the odds of sensitization to these foods. Another study on cow milk allergy showed that introduction of formula in the first 14 days of life and regularly thereafter significantly lowered IgE-mediated cow milk allergy as compared to introduction after 3 months of age. Which environment do you think is more protective against development of allergy? A clean environment or one in which there is increased microbial exposure? The hygiene hypothesis answers this question. It states that low exposure of the mother during pregnancy and of the newborn early in life to bacterial lipopolysaccharide-rich environment contributes to a T helper 2 biased immune response. Farm dust and endotoxin exposure induces an enzyme called A20, which is protective to the lung epithelial cells. And according to the hygiene hypothesis, to develop a normal gut microbiota and immune system, continuous microbial exposure is needed during the first month of life, and this is compromised by the excessive cleanliness and hygiene. And perhaps the hygiene hypothesis will drive all the mothers crazy. And this figure shows that the diversity of the gut microbiome was less in children who were sensitized to food allergens as compared to those who were not sensitized, but this was significant only at the age of 3 months. The GLADP guidelines recommend using prebiotics in non-exclusively breastfed infants and not to use it in exclusively breastfed infants. With respect to probiotics, they recommend using it in pregnant females or breastfeeding females who are at high risk of having an allergic child, and to use it also in infants who are at high risk of allergy. All these recommendations are conditional and are supported by very low quality evidence. The European Academy guidelines for food allergy and anaphylaxis does not find enough evidence to recommend its use as a means of prevention or treatment of patients with food allergy. Much contradiction surrounds the effect of the presence of cats and dogs perinatally on the risk of the development of food allergy. And a systematic review of longitudinal studies have shown that there is no effect of the presence of cats and dogs at home since birth on the risk of food allergy. This meta-analysis of all these studies showed that exposure to dogs reduced the risk of the development of atopic dermatitis. This is valid also for the ownership of pets in general, but not cats. Tobacco smoke. Perhaps this is the risk factor that there is no controversy about, and exposure to tobacco smoke prenatally and postnatally was found to increase the risk of sensitization to food allergens during the first 3 years of life, but not to inhalant allergens. This was from a multi-center allergy study group in Germany. Exposure to secondhand smoke during infancy was found to increase the risk of sensitization to food allergens as well as other allergens, indoors, outdoors, and inhalant allergens. Over the years, this is for children followed up to the age of 6 years, the overall effect was significant. So whether in utero or on the lab, smoking will remain a preventable risk factor. The COP6 study from Copenhagen is a prospective birth cohort study following children at risk of allergic disease up to the age of 7. This Kaplan-Meier curve shows that the cumulative risk for the development of atopic dermatitis up to the age of 7 was significantly higher in children born to mothers consuming alcohol versus those who were not. And I think this is one preventable factor. In spite of all these studies that I've mentioned, still we have a lot more to do. We have to know more about allergies, food allergies in the developing world, to know the frequency, the different food allergens in the developing world, and to understand the events that help drive towards natural tolerance acquisition. Most importantly is to know which of the risk factors is really modifiable and preventive in order to address it in the future. I would like to thank all my colleagues in the Pediatric Allergy and Immunology, Ain Shams University. And lastly, thank you all for your attention.